Hi, this is Dr. Scott Friedman with a summary of this month's focus piece that I wrote entitled Tracking HCC Pathogenesis but Not the Tumor Cells After Biopsy. The two articles I've chosen to summarize in this month's issue address two different aspects of hepatocellular carcinoma. The first is the pathogenesis and specifically the role of both autophagy and the NRF2 transcription factor. And the second is addressing a study that looks at the potential risk of tracking tumor cells after percutaneous liver biopsy in patients with HCC awaiting liver transplantation. The first study by Ni et al. Uses an animal model to ask what the impact is of deleting a very specific gene that controls a pathway in hepatocytes known as autophagy. As I've reviewed in previous focus pieces, autophagy is a critical intracellular pathway that normally degrades intracellular substrates. It's sort of a garbage pathway for intracellular products, but it also is a critical source of energy. And we know that when autophagy is defective, that does very unhealthy things to hepatocytes. Previous studies have looked at that using similar models as the study by Ni et al., which created a so-called CRE-LOX or selective targeted deletion of a key autophagy gene in hepatocytes called ATG5. And they showed that in mice whose hepatocytes lack this critical mediator of autophagy, in other words, when autophagy is crippled, the cells are severely damaged, fibrosis, liver injury, and ultimately hepatocellular carcinoma develop in this model. So it tells us that autophagy is critical for maintaining healthy hepatocyte homeostasis. And if you deplete autophagy or block it, this has very dire consequences for hepatocyte function. And it also leads to injury, fibrosis, and cancer. The additional component of this study that's extremely interesting is an analysis of what downstream mediators lead to this phenotype once you block autophagy. And to cut a long story short, their studies show genetically and also experimentally or biologically that a transcription factor known as NRF2 is critical for mediating the deleterious effects of blocking autophagy, such that when they create a double knockout mouse in which the hepatocytes lack both ATG7 as well as NRF2, the deleterious effects are lost. That tells us that NRF2 is critical for mediating those injurious effects of autophagy deficiency. Now this is a little puzzling and paradoxical because NRF2 is a transcription factor that normally activates antioxidant response genes, which should be a good thing. And so while we now have nailed down a key mediator of the effect of loss of autophagy and identified NRF2, we do not understand why a healthy, quote, healthy pathway like NRF2 that should drive antioxidant genes really has a dark side that ultimately amplifies liver injury due to autophagy deficiency. And so undoubtedly, future studies will dissect the mechanisms by which NRF2 gene activation, or rather activation of NRF target genes, leads to this very profound phenotype of hepatocellular injury, fibrosis, and cancer. The second study is one from the Hôpital Beaujon group, and Fuchs et al. Has examined the potential risk of tracking tumor cells when investigators or clinicians do skin needle biopsy in patients with hepatocellular carcinoma prior to liver transplantation. And specifically what they did is to examine the outcomes of 309 patients who underwent skinny needle biopsy prior to liver transplantation, and then looked at the outcome compared to patients who did not have a biopsy to determine if the risk of recurrence of HCC was greater if patients had a biopsy prior to their transplantation. And in short, the risk was not greater. The number of cases of tumor tracking was very small, and it underscores the fact that liver biopsy is, in the large majority of patients, safe and also has a very low risk of tracking HCC across the liver prior to transplantation. So this is an important practical study because it tells us that liver biopsy is feasible and generally very safe. Now, this becomes more and more of a critical issue because, ironically, we're moving back towards the hope of getting tumor tissue in advance of treatment for HCC. So as many of you know, traditionally biopsy was performed for HCC, but more recently practice guidelines do not require biopsy to establish a diagnosis of HCC. And so less and less biopsies are being done prior to definitive therapy for this cancer. But now we're in an era where genomic information from those tumors is very critical. And so we need to go back to obtaining tissue from these tumors in order to define the molecular defects or pathways that are specifically dysregulated in an individual tumor. And this really points to the future of HCC treatment, which undoubtedly will include much more personalized or individualized therapy using agents that are specifically directed at pathways that are dysregulated in a patient's tumor. And so it's really an important observation that we can safely do biopsy in patients with HCC, with one caveat, which is that the patients in the biopsied versus the non-biopsied group were not matched for tumor stage. Notwithstanding that, I think that this clinical study is an important reinforcement of the ability to safely do biopsy in helping acquire tissue in order to develop more personalized approaches to hepatocellular carcinoma. And so in summary, these two articles give us two different elements of what is clearly one of the most challenging aspects of hepatology, the diagnosis, understanding, and management of hepatocellular carcinoma.